are in triage of the emergency department when a 58-year-old female with a history of Wolff-Parkinson-White syndrome comes in and complains to you of dizziness and palpitations. You take her vital signs and get the following data. Heart rate equals 210 beats per minute. Blood pressure equals 90/60 millimeters of mercury. Respiratory rate equals 22 breaths per minute. Temperature equals 36.1 degrees Celsius. Oxygen saturation equals 97%. The emergency room physician orders to place her on a biphasic defibrillator, and you monitor the following rhythm. Question 1. What is the ECG interpretation of the rhythm strip above? A. Sinus tachycardia. B. Paroxysmal supraventricular tachycardia. C. Ventricular tachycardia. D. Ventricular fibrillation. Correct answer, B. Paroxysmal supraventricular tachycardia. Paroxysmal supraventricular tachycardia is a tachyarrhythmia that originates anywhere above the level of the bundle of His. This pattern of ECG is a paroxysmal supraventricular tachycardia, which has been provoked by an accessory pathway due to Wolff-Parkinson-White syndrome. A heart rate of 210 beats per minute distinguishes this finding from sinus tachycardia. Incorrect answers. Sinus tachycardia is incorrect because of the indistinguishable P wave from the T wave and faster heart rate. Ventricular tachycardia will present as wide QRS complexes, and in this case, the QRS complex is narrow. Ventricular fibrillation, VF, is incorrect because VF has an irregular rhythm and absent QRS complex. Question 2. What is the next appropriate step for this patient? A. Synchronized cardioversion. B. Sedate patient. C. Defibrillate. D. Perform intravenous access. Correct answer, D. Perform intravenous access. Following the American Heart Association algorithm for a narrow QRS complex tachycardia with a pulse, the next step after assessing the ECG is to gain intravenous access or medications that can potentially revert this arrhythmia to normal sinus rhythm. Another possible emergency treatment is performing vagal maneuvers while awaiting for the placement of an intravenous catheter. Is reserved for regular narrow QRS complex tachycardia with a pulse only if the patient is hypotensive, incoherent, has signs of shock, ischemic chest discomfort, or is in acute heart failure. The patient is in neither of these states. Sedation is considered before performing synchronized cardioversion, but since it is not recommended at this time, sedation is an incorrect answer. The team has inserted an intravenous catheter. Question 3. What is the drug of choice for this patient? A. Adenosine 6 mg rapid IV push. B. Procainamide 20 to 50 mg per minute intravenous infusion until arrhythmia is suppressed. C. Amiodarone 150 mg intravenous infusion over 10 minutes. D. Sotalol 100 mg intravenous infusion over 5 minutes. Correct answer, A. Adenosine 6 mg rapid IV push. After close inspection of the ECG, it is established that the patient has paroxysmal supraventricular tachycardia. Incorrect answers. The following drugs in the choice set, procainamide, amiodarone, lidocaine, and sotalol, are antiarrhythmic drugs for stable, wide QRS tachycardia. Paroxysmal supraventricular tachycardia is refractory to adenosine or vagal maneuvers. Are calcium channel blockers, amiodarone, beta blockers, sotalol may be tried. Beta blockers and calcium channel blockers have slow onset of action and can destabilize this patient due to its hypotensive effects. Therefore, these medicines are only considered after attempting vagal maneuvers and AV nodal blocking agent, such as adenosine. After giving 1 dose of adenosine and attempting vagal maneuvers for 1 minute, the patient's arrhythmia persists. She still has the same vital signs and is coherent. Question 4. What is the next most appropriate treatment for this patient? A. Administer adenosine 12 mg followed by normal saline flush. B. Apply advanced airway with waveform capnography. C. Sedate patient, then synchronized cardioversion. D. Perform precordial thump. Correct answer A. Administer adenosine 12 mg followed by normal saline flush. If the first dose of adenosine 6 mg is ineffective, the second dose must be increased to 12 mg followed by a normal saline flush. The patient is still hemodynamically stable in the sense that she is not hypotensive, has no altered mental status, she is not in shock or in ischemic chest discomfort. Therefore, a less invasive and known effective procedure, such as pharmacologic treatment with adenosine, is recommended, rather than advanced airway and synchronized cardioversion. Studies have shown that a precordial thump has some utility in out-of-hospital witnessed cardiac arrest. However, in the hospital setting, this is not recommended. After administering the previous therapy, the patient has not improved. Question 5. What is the next most appropriate treatment for this patient? A. Administer another dose of adenosine 12 mg followed by normal saline flush. B. Seek expert help immediately. C. Sedate the patient followed by synchronized cardioversion. D. Insert advanced airway. Correct answer: seek expert help immediately.